Good morning, everyone, and welcome to our GP Paediatrician Interface and Transitions for Young People webinar. My name is Helene, and I'm the Workforce Development Officer at Western Victoria Primary Health Network. I will be facilitating and doing the introduction this morning. Alongside me is Katrina Martin, who is the Program Lead for the Workforce Development. This webinar will be an introduction to healthcare transitions, in particular paediatrician GP transitions for young adults. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience, and the ongoing place the First Peoples hold in our communities. We pay our respect to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations and work together in closing the gap. Just a little bit of housekeeping. The majority of our webinars are recorded and freely available on our PHN Learn YouTube channel. Katrina will put the link to our recorded webinar events into the chat. I have our upcoming events on the screen coming up, so you can register for our events on the website, and Katrina will also put them in the chat for you. Our intellectual disability ECHO registrations are now open for Series 3 of this ECHO series. These case-based ECHO sessions will run fortnightly throughout Term 4 from 7:30 to 8:30 a.m. on a Tuesday morning. Many of the presenters and panel members you will hear today are regulars at our ECHO sessions. Registration is open to all of the healthcare disciplines. We are excited to announce that GPs can use Series 3 as a 40-point CPT activity. The requirements are on the screen. Katrina will put a link in the chat to register, or you can scan the QR code on your screen. Please check the box if you wish to use this as a 40-point activity, and we'll make contact with you. There's no need to re-register if you have attended previously. Please make note of the West Vic PHN Health pathways relating to this topic that is on the screen at the moment. For our Tasmanian counterparts, please see your relevant health pathways on this next slide. We have also collated a list of resources from the Council for Intellectual Disabilities. Katrina will pop that into the link to the chat for you. For today's webinar, all participants will remain on mute. If you have questions, please type them into the question and answer box, not the chat box, and I will ask them on your behalf to the presenter during question and answer time. All questions in the question and answer box are anonymous. We do know that for some reason, the software does block the Q&A function for some attendees. If you have a question but don't have access to the Q&A box, then please type them in the chat box. However, please be mindful that this will not be anonymous, and please be always respectful to other attendees and presenters, refraining from negative comments, please. We ask that you complete the survey after today's webinar. We'll put the link in that chat box and display a QR code on the screen at the end of the session. I will now hand over to the presenter, Evelyn Culnane. Thanks, Evelyn. We'll get commencing with yourself.
Thanks, Helene. With me today, I'm really very pleased to present my co-presenters for this morning's presentation, Doctors Jane Tracy and Robert Ward, who will share their perspectives, both as practitioners, GPs in the field, but most importantly as parents of adults with an intellectual and developmental disability too. So today we hope to share with you some of what young people and parents and carers tell us about what they need and want during the transition process. What does transition mean to them? We'd like to share with you, describe how GPs and healthcare providers can support people with an intellectual disability and their parents and carers during this transition process, and identify the challenges, both the challenges and enablers faced during transition by young people with an intellectual disability, their parents and carers, GPs and other healthcare providers. So when we asked families and young people with a range of different medical conditions, including those with an intellectual disability, what they would like transition to feel like. These were some of the key words that they provided for us, and really it comes as no surprise to us as practitioners, but it's really important as we need to keep these in mind in order to develop the right processes. We really do need to know what families and young people need. So the themes of feeling comfortable, transition being a process that's talked through, that starts early, sort of like a high school transition was what one young person identified. They needed it to feel empowered. So how do we actually achieve that through the transition process? The RECP developed some guidelines around the transition of young people with chronic disability needs in 2014. And it was recommended that it's really an opportunity for us to respond to the changing needs of young people with chronic and complex disabilities. It's a formal process which involves preparation while the child is attending paediatric services, a period of conjoint activities between paediatric, adult and community care, and the appropriate and comprehensive orientation to ongoing adult care. So really this is what it's describing, that process of preparatory support in paediatric care, period of conjoint processes and ongoing transition care, which continues throughout the whole of life. So what do we need to consider during the transition process? We had raised earlier the notion that transition really does need to start early, and that provides us with an opportunity as clinicians to really understand what the young person and parent carer needs through the journey, what support systems do we need to put in place, and understanding that transition is a very individual and flexible process. We need to establish expectations in the context of differences between paediatric and adult care systems. There's a great deal of literature that suggests that paediatric and adult healthcare, we know that paediatric and adult healthcare systems are very different. Jane will touch upon that later on, but we know that there's, particularly in that context, the understanding that these healthcare systems can be somewhat challenging to navigate at times, understanding what sort of support systems young people and families need, and establishing those expectations at the outset is really quite important. We need to think about who will play the role of the transition lead. That could be a treating GP, it could be a specialist, it could be someone like a transition lead if there is one available at the hospital. And that clarification of roles and responsibilities of each clinician, of the parent and carer, of the young person involved in the transition process is ultimately what we need to do to avoid confusion, to enable a comprehensive plan to be initiated. I put this down as point 4, but it's certainly probably the most important point, and that is communication. We need to establish what good communication is, and always communicating back to the young person and family. I think it's often assumed as clinicians that information reaches the patient and family, but that's not always the case. And that brings about potentially a great deal of confusion and angst for families and young people if the right information is not communicated in a cohesive and comprehensive way. And also access to information. We really do need to ensure that clinical leads, the family, the patient have access to the right information throughout the transition process and beyond to enable that ongoing care. So how we do that, it really depends on the healthcare system itself. We know that we're all challenged by different databases and different systems, and how we actually manage that access to information process is really quite important. Some of the things that we need to consider during the transition process are not only about what medical links are needed. We need to think about the wider support needs for the young person and family. Who are the nursing leads? Who are the allied health leads within the hospital system, in the community? And that young person and family having the contact details of those key leads to enable that ongoing care. So we need to also think about emergency planning and really clear guidance for young people and families around where to present in the case of an emergency. How will that look? One of the key questions that families always raise with us is, can I stay in the case of an admission or emergency in a hospital system? Are there provisions in an adult hospital? And that's something that is front of mind for a lot of families, particularly those who have young people with a disability. And it's something we need to address with these families. So in most instances, almost all instances, adult hospitals will accommodate family members, appreciating that they are often and they can be the spokesperson for the person with a disability. But to understand also that unlike a paediatric setting, they may not have a fold-out bed. They may have access to a recliner chair or a chair at best. But the provision to stay is certainly an option in most cases, and it's all about common sense. I think that's also challenged during the time of COVID, where perhaps only one family member can attend the appointment or no family members. So being able to communicate that need prior to the appointment is really quite important. Advanced care planning, understanding whose responsibility it is as clinicians to embark on that process, what's needed for parents and carers and young people to think about what an advanced care plan means for them. Decision making and power of attorney and the young person's capacity to make decisions. How do we decide that? Those are the sorts of questions we need to think about well prior to transfer to adult care. And Jane and Robert will touch on that later. We need to think about the differences between medications and equipment in paediatric versus adult care. Access may be different, there may be additional costs, and we really do need to plan for those things well prior to transfer, because that's the last thing we want to go awry during the transition. Immunisations and sedation. Often paediatrics provide sedation quite easily in the paediatric setting. It's not always available and often not available in adult services. So how do we actually manage that? How do we establish the right support systems for young people in an adult hospital system and in the community? We know dentistry, although it's last on the list, it's certainly not the least important. Special needs dentistry at the moment is quite scarce. Waiting lists are very long. We need to anticipate these waiting lists, and dentistry is a key part of care for young people. And community links, we need to ensure that young person has, and the family, have a GP throughout their child and adult life. And we need to ensure that that GP is communicated with throughout that journey and involved. Disability services, understanding what supports are needed throughout the transition process, other concessions, financial and other, and also issues like guardianship and power of attorney, financial issues need to be considered. So there's a whole range of different considerations, and I think, as you can see, transition's not just about medical care transfers. So ideally, transition should be about just a good clinical care. This is an example of a booklet that we developed for young people with an intellectual disability and autism, and it demonstrates one process that we have in place to enable shared communication and shared care between GPs and other practitioners and paediatricians. and that's available on the RCH transition website. So from the perspective of a paediatrician, this will be my final slide. Catherine Mareffa, a paediatrician and autism paediatrician lead at the Children's, shares her top three tips for a good transition. From her perspective, it's really understanding and helping a family to find a GP early in the child's life to ensure that transition is as smooth as possible. We know that from previous research, proportionately, a lot of our families don't have access to a regular GP at the point of transfer to adult care, and that's quite concerning. We need to ensure that, much like we mentioned before, that the GP has access to all the young person's medical records, including growth charts and immunisation status. And being able to regularly update and check the medications are current with parents and carers and with the young person. This should be done at each visit, ideally, and even more so and even more regularly during the transition process. I'd like to hand over now to Jane.
Thank you, Evelyn. Yes, so my name's Jane Tracy. I'm a GP by training, but have worked in disability medicine for the last 30 years. And I did so really because of my son, Nick, who's now 37. And he, like many children with disabilities, had complex needs in childhood. And those complex needs, of course, continue in adulthood. Sorry, just taking control of the slides here. Okay, there we go. As Evelyn said, the differences between paediatric and adult services can be quite stark, and transition is a time when it's not just for health services that transition is occurring, it's also for social services. The young person is leaving school, is leaving the support network that was around them at school, and even from a legal point of view, the age of 18 has legal implications for consent. And so it's really important when we're thinking about transition to start that planning early. You know, start thinking about it when your patient is 15, 16, because there's some preparation that happens then. The disability support pension, for instance, starts around 16, so that they can get to Centrelink, find out about their rights, establish bank accounts for the young person, do all of those things before the age of 18. So paediatric services, there's an expectation that children with developmental disabilities have complex needs, and the complexity is seen as just inherent in their care and requiring a multidisciplinary approach, with the GP working with a specialist, in this case a paediatrician, with appropriate referrals to people as required. And there's a focus on the young person in the context of their family and support network, so that there's an expectation that health professionals are working with the young person and with their support network. Very similar situation in aged care. We have an expectation there are comorbidities, that there's a complexity of care, that the GP, if the complexity of care is such that they need a geriatrician, that the GP is working with a geriatrician. Once again, the importance of multidisciplinary care and a focus on working with the support network and family. But our system has, between the ages of 18 and 65, a different kind of philosophy where it's very much focused on single organ systems. The GP alone is the one coordinating care, and there's an emphasis on individual care, self-directed care, autonomy and agency. And that is a very difficult system sometimes for families and young people to enter when they have a complexity of care relating to their developmental disability. The other thing that compounds the issue is that during paediatric years, there's often an intensity of input in the first 10 years of the child's life, but then sometimes that that contact with health services can decrease as they approach the age of 18. And so the paediatrician may not be such a prominent person in the family's life by the time transition occurs. And so once again, the importance of the GP being proactive and asking who was the paediatrician and getting the appropriate handover from the paediatrician, the appropriate summary of care, is such an important part of taking over responsibility for the coordination and provision of care in adult years. So when I'm thinking about transition and the preparation for that, as we've talked about, the importance of information, it's important as much as possible, and this is increasingly happening, where paediatricians are involving the GP and communicating regularly with the GP throughout the childhood years. It still doesn't happen quite as often as it should, and there are still problems with the system there, but there is a shift over the last 10 years that is happening more. And there are also information that the parents need about medical treatment decision making that comes into play after the person is 18. They continue, if the person is not capable of making decisions, parents can continue to do so as the medical treatment decision maker. But there's an expectation that as much as possible, the young person is involved in those decisions around their health and healthcare and well-being. As the young person approaches the age of or late teens, we want to make sure that we're, and really this starts very young, increasing the involvement of the young person, helping them to take as much responsibility for their health care as possible and appropriate, to be actively involved in decision making around their health and health care, and encourage that young person to speak directly for themselves. If that requires the use of a communication device, the bottom picture shows the iPad that my son uses for communication. He has cerebral palsy, so he doesn't use speech to communicate, but communicates through an app on his iPad. And it's very important that people take the time and the effort to allow him to speak for himself as much as possible, because that's part of being an adult and being able to be an active participant in adult care. And the building of a sense of partnership with the young person and family members, that the GP can be there as a partner, as a resource for the young person, for the family, as they navigate through transition into adult services. And why is all this important? Well, because we spend most of our years in our adult years, and good health is important to our quality of life, of course. And when we're talking about good health, we're talking about physical health, of course, and it's very important that that we encourage the young person to maintain their physical health and function as much as possible. Mental health is also important, and that's about relationships and connectedness and belonging and being included. Dental and oral health, as Evelyn said, very important, and for those families who can afford it, private health insurance can be very helpful in the care of people with disability. My son has epilepsy as well as cerebral palsy, and has required a lot of dental work for broken teeth after falls, for orthodontic work, and for a number of other dental procedures. And having private health insurance has been immensely important in enabling him to access the dental care he needs, and social and emotional health. And when we have an optimum quality of life, we have optimal comfort and well-being, function and independence, and communication, and the opportunity to be a participant and a contributor to our communities. Thank you. And I'll hand over now to Robert, my colleague who's a GP, who's in real practice and also has that experience of being both a parent and a professional. Thank you, Robert.
Thanks, Jane, and thanks for having me here today. My name's Robert Ward, and I'm a GP in Geelong, and I've been a full-time GP for the last 28 years. And like Jane, I've also got that sort of lived experience of having a child with an intellectual disability and complex needs. And that journey for our family began about 25 years ago, with speech and motor delay and poor feeding and irritability, screaming, scoliosis surgeries, ankle surgeries, all the sort of the whole kit and caboodle really for us. And we were really well supported by our paediatrician. And the Royal Children's Hospital. My son went to a specialist school where he had specialist teachers, occupational therapists, physios, speech therapists, and they were all working with us and my son, and it was really a very stable time for us. And then when you hit 18, the school has a bit of a graduation. There was a DEB ceremony. You celebrate your achievements, and then you popped out into this other world, sort of the adult world of disability. And that's probably that transition period which I want to talk about today. So let me just, if I can flick the slide over. So during the transition period, there are many changes, and probably what I'd like to do is just to first acknowledge that there's lots of different, a great diversity in disability and in the community and in the families of the people caring for these young people, and we all have our unique strengths and challenges and cultures and linguistic backgrounds and trauma experience. And also with my colleagues in general practice, we also have diverse backgrounds and different strengths and different weaknesses and special interests. And I'd probably, when we go through this transition story, I'd never like to judge any families or doctors on their ability to make that connection and to provide good care. And sometimes it's a bit of a work in progress, and to realise that we all are a bit different, we all do have our strengths, and we need to acknowledge that when we're doing the transition process to work out what's best for that individual patient. So really during the transition, the patients change, and as has been said, they're not a small child with complex needs anymore, they're a big adult with complex needs. And all of a sudden, instead of this sort of caring, holistic approach, you've got a lot of people out there who are asking you, what do you want and how do you want us to help you? So the previous holistic multidisciplinary team approach is suddenly replaced by this individual self-directed disease-focused approach. And you're not at school anymore. As a patient, you're a young adult. You might have to get a job, you have to find taxis, you might have to enroll in a day program. There's a whole lot of other things that are going on. And your paediatrician's not there looking after you, and you might have connected with a GP, or you might have to find a connection with a new GP to help support you on your journey. And you can also say no to things now. You're 18. You can say no. I don't want that flu shot. I don't want to see the doctor. I don't want to go to day program. I just want to sit and watch my DVDs all day. I might want to eat unhealthy food and eat McDonald's every day. So you're able to take risks. You might even hang out with the wrong crowd. So lots of challenges here for a young person during that transition time. And also the transition period and that teenage period is an increased risk of mental health issues with young people as that goes forward. The other thing that also changes is the support at home. So just as young people grow up, also their family circumstances change. If you're really lucky as a young person, you'll have parents who are available and able to support you for many years. But for others, that might be grandparents. But even invariably over time, these supports change. Parents get older, grandparents get older, siblings move out, the whole dynamic in the household changes. And so you may find yourself increasingly reliant on paid support staff. And for some people, that may be at a really young age. And you might find yourself living in a supported accommodation with disability support staff looking after you, with a varying degree of family involvement. And certainly I see that in general practice, where some families are very involved and some families I don't know, and I only look after the person through disability support workers. So one of the challenges in entering the adult health field is really accessing healthcare, because that can certainly be a challenge. Whereas previously it had been a very planned approach with lots of people helping support you, you're sort of out there on your own in this adult health field now. So it may be harder to get regular checkups because the checkups with the paediatrician have stopped, and I would imagine there'd be a lot of people who would almost use their paediatrician as a substitute for their general practitioner with regular visits. It may be harder to find a health practitioner that actually knows your health story. It depends on how the communication has been, and all of a sudden you're seeing someone who doesn't know you and they don't know you that well. You may be brought to see a doctor who doesn't know you well by a support worker who doesn't know you that well as well, and they don't understand what you're trying to tell them, especially if you communicate through behaviours or non-verbal. Sometimes your disability may make it really difficult for you to actually attend health appointments due to sort of behaviours, anxiety. So that certainly makes it more difficult as an adult to access blood tests, immunisation, or even checking your blood pressure that most people even just take for granted. Can be near impossible for some people with a disability. And Evelyn mentioned the dental services before, and a lot of the hospital services have lots of barriers that get sort of thrown up for people with a disability as well, that make it more difficult, whether it's that communication with the hospital system or accessing sedation for certain procedures. Even for dental services, trying to get an OPG X-ray on a person with a disability, because it's a requirement that the dentists need, and that's a block for them accessing that service. And we know that people have with disability have poorer health outcomes. So what are the challenges for the GP in the transition period? General practice is really very busy, and particularly over the last few years, and I think we're a bit of a hamster wheel, sort of churning through 10-minute appointments with very little downtime. And I don't think we really get much formal training in looking after people with complex needs, particularly people with disability, because it's often seen as the realm of the paediatrician. And suddenly when you start general practice, you're realising that that you do have a role here. So we don't get much formal training, and sometimes our confidence is not there. But as part of the transition, having a GP is one of the few possible constants in a young person's health journey. So it's really important in general practice. We try to find where we fit in, and we try to engage with this young person for that long-term care, because we are good listeners, and hopefully we can be good advocates for our patients as well. Sometimes we do wonder where we fit in, and in the early years we're often not given much of a role, apart from writing a new referral and to the paediatrician or collating 6-monthly letters from the paediatrician. And we get sort of lovely letters from the paediatrician that I can collect in a nice little file, but I don't actually see the patient, so I don't actually engage with the patient. The patient doesn't get used to seeing me. I don't get used to seeing what the patient's communication style is. I think the other challenge for general practice is communication, not only with the paediatrician, but with all the allied health and all the other people that are looking after these patients. And that goes two ways as well. I don't think in general practice we're very good at communicating with the allied health team. One, because we don't know who they are. Two, because they keep changing. And we're just not often pretty time poor at communicating our concerns. Accessibility for general practice, because we are all really busy. That may be a lot harder for people, especially if they're trying to access us through disability support staff. And thinking long term, I don't think general practice, particularly when you start out in general practice, you're often used to thinking about long term planning, because we are looking after these people long term. And the other thing is the support out there. There's probably not a lot of other specialist support that we're often used to in general practice. When there's a heart problem, we use a cardiologist, very disease-centric specialties in adult medicine, and we sort of miss that with these complex care needs. So often in general practice, we feel a little bit alone and a bit challenged. So if we go to the next slide. One of the things also for carers, so for parents and family, it's quite a challenging time. Certainly as your child gets into the adult sphere. When they're at school, you can sort of pretend that life's a little bit normal, because every other parent you meet have their kids at school and everyone is at school, and that's a normal thing. Then all of a sudden your child's not at school, they're meant to be doing something else, and so it becomes a new challenge for parents and carers. And you do, I think, go through a bit of a grieving process, because it sort of highlights the things that you might have otherwise been experiencing now, and previously you could sort of pretend in a little way. And it's also a time to have to think about the future as well, which is a challenge. Certainly in my family, it's a challenge to think about future needs, and it's probably a discussion that we back away from. I'm sure there's lots of parents whose long-term plan is to outlive their child, and continue providing support, and just become their role as a quiet, ever more isolated carer, which is not probably the best thing for them. Support workers also changed. Look, I've worked with a lot of support workers, and they are incredibly compassionate and wonderful people. They've all done their NDS training, and they're fully into letting the patient self-direct their care, which is fantastic, and good at communicating. But they're generally young, they're generally transient, they're not well paid, and sometimes we ask them to support people with really complex needs, with seizures and behaviours, and they're all quite challenging, and we expect a support worker to be able to interact with the health system that's a little bit impenetrable sometimes, and that's the support the patient needs. So sometimes I really wonder who's coordinating it all, because sometimes as a GP I don't get a sense I'm coordinating it. I don't necessarily have contact with all the other health professionals or the allied health that are looking after patients. So really with transitions are a period of risk. So risk of sort of medical information getting lost, things not being passed on, going into a system that doesn't know you. So all the stuff you've done in the last 18 years may not be documented or not known to this whole new system that's starting to look after you. And I know with the ECHO project, a lot of the case studies always involve a bit of a transition. It's either the parents have died, or the doctor has retired, or someone has moved house, and so that transition period in lots of ways provides a risk for the patient. However, the transition from adolescence to adulthood is very predictable. We've got 18 years to work it out, so it's very plannable. But often for the patient and their family, it's their first time. They don't know about this transition coming up. They've been happy with their little their system and the people looking after them, and so I suppose it's up to us as health professionals, because it's probably not our first rodeo, and we should be planning and supporting our patient through this time and acknowledging that it is a period of risk. So finally, I'd like to really that sort of paediatrician to GP interface. I'd love to start really early. I would go really from very young in childhood to interact with a GP, or to find a GP who's going to be there for the journey with you. Someone who you feel comfortable with as a parent, who's going to be around for a while, who you can communicate with well. And I'd like to empower that GP through the paediatrician as well, to actually see the patient on a regular basis, and become just connecting with them once a year, just to find out what's been going on, to update the medical records, engaging with the family, learning how to communicate with the patient, learning how to examine them, what they can and can't do. And sometimes those checkups, even if there's nothing specific, it just gets that annual checkup just as a regular connection with someone, and that can continue into adult life. You don't need to be unwell to see a doctor, but it's just really checking in and see where you're going. I'd love to see the GPs supported with a little bit of a roadmap at that time of transition as to what to expect with this specific patient, specifically if there's a specific syndrome or things that we need to look out for. It would be nice to have a little bit of a head start about what we need to look out for that person. I'd love for the communication to be improved, and that's really with all the allied health that are looking after our patients. I certainly look after a number of patients who live in supported accommodation, have behaviours of concern, that are on medication for behaviours, and yet I find out they've got an occupational therapist and a speech therapist and a behavioural support therapist that I've never heard of. and yet the disability support worker will come and ask me for PRN medication. And there is no communication. I don't know how to get hold of these other people, and I'm probably a bit ashamed that I haven't made contact with them either. So looking at that communication moving forward would be really important. And finally, for the GPs and for everyone involved, just to preserve that health story, to go back. So, because we're going to be looking after this patient, or someone's going to be looking after this patient into their 40s, 50s, and 60s. And so it'd be nice for that story not to get lost or diluted, and so people can go back to say, this is the diagnosis, this is the things that have been tried in the past, this is how this person communicates, and this is how we can best facilitate their health moving forward. So thank you.
Thanks, everyone. I'd like to thank Robert and Jane for providing their professional and personal perspectives. Helene, I understand that you had a few points for our attendees prior to question time.
Yes, I don't actually have any questions come in to the question and answer box yet, so I will hand back to the three presenters. They may have some finishing conversations that they would like to say. Thank you. Thanks,
Helene. Robert, you raised a really great point around communication and the notion that GPs should be involved throughout that transition process, and do you have some ideas about how that communication system could be built or established during the transitions to enable that communication between hospital services, patients and families, and other providers?
Look, I suppose it'd be nice to actually have a list of those people who are looking after it. I think it's hard to communicate someone who you don't know who it is. If that's the speech therapist or the occupational therapist or the behaviour support person. If I don't know who they are, that can be difficult. I know as general practitioners we can be really hard to get hold of. It's not easy just to phone up and talk to a GP because we're all sitting in front of a patient at the time, and I imagine that would be incredibly frustrating for that. And we probably don't use emails as much as we used to, or as much as we should, because we're still on the old fax machine. So I think there's
sorry.
That's all right. So I think there's probably a few things there. I mean, it'd be great to have sort of meetings with everyone and to do that, and to feel empowered to do that, and to feel that's part of your role as a GP, because sometimes I think we don't really know that is our role.
Absolutely. I think that roundtable discussion is so important. Sorry, Jane.
Yeah, no, I was just going to say in relation to that, Robert, I think some of the Medicare items are very useful to highlight here. The health assessment item for people with intellectual disability that gives GPs an ability to spend a bit more time with people and to get that overall picture, that holistic picture, and to prepare for transition. And also case conferencing can be very useful with other health professionals. And it's so much easier than it used to be because everybody can be on Zoom from wherever they are, rather than try to get everybody into a same room together, which is, of course, impossible. So those are strategies that we can use that are very useful in this kind of very complex group.
Yeah, and look, and I think that's really good. I think one of the difficulties with the annual health assessment item number is that you have to pre-plan it a little bit. It's there's certain requirements that are needed from Medicare. It's not just spending a long appointment with the patient. So I think that's probably a little bit of pre-planning, and it may be difficult for a GP who just has one or two patients and suddenly they drop in for a long consult to be, unless you've really thought about how you're going to do that, it may be hard to fulfill the Medicare requirements. And I mean also the getting together on a Zoom meeting can also be difficult for a GP in a busy session. If you've got appointments and you're running half an hour late, that slotting in a Zoom meeting bang on time with three other people can be a little bit challenging when you've got people in the waiting room who are already running half an hour late.
That's true, but the health assessments for people with age over 75 are used all the time, and it's a very similar format.
Yep.
So it's just a matter. It's like anything. When you're not familiar with it, it sounds it's a little bit harder. And once you do a few, then you can see the sort of the sense in them, I suppose.
Oh, absolutely.
Yeah.
If you do them, and I think they are a terrific tool to use. I wonder if the over 75 ones, because we have a higher population of people over 75, and we can get the nurse churning through them, and people see an economic sense in doing them. So there's a bit of a financial incentive to do the over 75s. As a whole practice point of view, I probably don't get that sense with people with complex needs with an intellectual disability. It's more of an individual GP sort of saying this is important for my practice.
I do have a question come in. Thank you very much for an excellent presentation today. From the health professional perspective, are there opportunities for NDIS funding to support the transition period? If not within the health system itself, do you have recommendations of NDIS funding to support some continuity of supports for the person and family?
Can I answer that? And I think we mentioned the role of a transition coordinator or transition lead prior, and I think the NDIS certainly has a role to play, and perhaps the support coordinators or clinicians involved in that young person's care could play that role. So Robert mentioned having a database, for example, or a list of practitioners involved in that young person's care. That's something that could be easily developed by an NDIS provider in consultation with the family and the young person. So having a bit of a document, passport, contacts list during that transition would be something that could be quite doable by a support coordinator or practitioner. And also being able to coordinate that care, establishing links between GPs, specialists in hospitals, community providers. They're actually in a great position to be able to coordinate that process.
Just a couple of other things that have come through the chat. We have a question. As a new transition worker, I'm curious to learn whether there is a list/database to find out which GPs in the region have expertise in working with disability. That's a Bowen Health, the Geelong region question.
Perhaps I'll throw over to Rob and Jane, but certainly from the RCH, we keep a list, an informal list of GPs that families are very happy with and recommend. And that's really used on a needs basis, and we would encourage families and young people to find their GPs independently, to communicate with other members of their community to determine other connections and other recommendations in their area, and to draw upon the expertise of their existing GP networks. The list that we have is really just a fallback position if that family has tried a number of practices and haven't been quite successful. So in answer to that, no.
I'm not aware of any list. No, just so I'm not aware of any list for an occupational therapist who's good for the GPs to refer to.
The College of GPs is starting to. The College of GPs has a disability special interest group, so there is a group of GPs who are developing interest and expertise in that area. But that's across Australia, and there aren't all that many. So no, I think as Evelyn said, it's best to start locally and just work together in partnership with the family to build the skills of the GP and the confidence of the GP and the other health professionals and the family together. The other thing in terms of preparation for transition is Robert mentioned behaviour before. Some people with intellectual disability or autism spectrum disorders can have some quite challenging behaviours. And it's so important that the strategies that have worked in childhood, early childhood, are revised and thought about as to their appropriateness for post-pubertal people, because many families get into a situation where they have used physical restraint or other strategies that just don't work when the person has more sense of their own agency and autonomy and are bigger physically. So that one of the preparations for transition is the development of behaviour strategies for this young person, and communication, optimising independence in communication for the young person.
Just another comment that has come through. As a practice manager of a PED practice and mother of a young adult with a disability, I have recently gone through this. It would be great if the PED/GP and allied health team meet and plan the transition.
Helene, in response to that question, again, the role of a transition lead is integral in that process. So identifying who is going to take that role. It could be the GP, it could be a specialist, it could be a transition manager in a hospital. Certainly that's the role that I play at the Children's, but however, that's certainly not confined to my role, specifically as that role isn't available in all hospitals and in all settings. So I guess as a family, understanding and identifying who that transition lead could be and starting that process early is really quite important. And that will enable that meeting, that roundtable meeting. And absolutely agree, that's the best mechanism to transition a young person across safely and supportively to adult care.
I don't have any other questions at this stage. Could I just take the opportunity?
Helene.
Yeah.
Sorry, Helene, there is another one here that I don't think was addressed. As an OT, I'm pleased to hear you welcome communication from us. Would you have a preference for this in written form or even keen to attend team meetings, etc.?
I would love a written form or a phone call even. Any communication I think is really good. Yeah, and with especially if we've got a specific goal in mind or a specific behaviour or specific issue to nut out, you know, what's actually happening with the patient. I mean, I certainly see lots of patients, and you find out that they do have an OT, once a month, and I don't really know what they're doing. So that'd be terrific to get that sort of communication and make sure all our goals are sort of focused. That would be fantastic.
Okay, so thank you to all our presenters for this such an interesting webinar this morning. Please make note of everything in the chats, the resources and the evaluation to be completed. Thank you again, presenters. That was fantastic. And I'm sure we will see you again at our next disability meeting. Thank you, everyone.
Thank you.
Thank you very much.